I'm Professor Peter Torzilli, right? Was that
That's
right?
correct, yeah.
Perfect. I'm Jose Mokhtarzadeh, and we are in Auckland, New Zealand, and we are finishing ABC, Australian or Australasian Biomechanics Conference. Professor Peter Torzilli has been working in this area for more than 40 years, right?
More than 45, yeah.
45.
45.
Amazing, nearly 50 years. Perfect.
Yeah.
So he's done he's done
Because I'm old.
you're still young and you're active, amazing. So you have been doing a lot, Peter. So in this area, especially cartilage, biomechanics, from different scales,
Right.
from organ scales all the way to cellular level, right? Just briefly tell us what you learned during this conference in the last couple of days.
Oh, from the conference? Oh, I've actually learned quite a bit. Uh, I've learned that looking at one single component of, let's say, the knee or the component of the musculoskeletal system is probably not enough to really understand the entire picture. Uh, you need to look at the whole patient. You need to look at not only the cartilage and the bone and the knee motion, but also maybe the muscles that are involved in that situation. And also, which was new for me, I hadn't really thought much about it, was the neuromuscular feedback system. When Peter Hunter gave that lecture,
That's a key.
really brought to life uh, that's an important part for stability, controlling the muscles and proprioception. So, and I talked to a few researchers, and they've said basically the same thing. They said we really need to put in the nerve feedback system and the muscles, which we don't do at my own institute. And I think we'll probably have to start doing that in a lot of our research,
So if
especially when it's a patient-specific now kind of medical treatments.
Oh, that's amazing. If you because the people who might listen to this or watch us might not necessarily be biomechanics, so
Mhm.
we would like to have like lay terms as well. So when you say neuromuscular, and then we're talking about cartilage, so there are to like a layperson might mean when we say neuromuscular, it comes from brain and then to muscle, and cartilage is something inside the joint.
Right.
So
So
how they are
cartilage has no nerves or blood vessels, so it doesn't feel pain. Uh, and also to treat it is difficult because if you were to take a drug or some kind of injection, it has to get to a tissue that doesn't have a blood supply. So it could be diffused into the joint cavity. But the neuromuscular part is is so when you're walking, if you were to change your walking style, gait, even in sports, or if you get an injury, and now you change the way you walk because of the pain, and a lot of times sometimes it's known as cognitive inhibition. You may not really have pain, but you may think you're getting pain. So it happens in the hip. People will change the way they walk because they're afraid they're going to, feel pain. Also, the fact that your brain is going to control the muscle firing, and so that feedback to the joint is going to control how you use your joints. And so if we don't think about that as one of the things associated with instability or changing how you might use a joint that can get arthritis, it could be hands, it could be shoulders, knees and hips are the common ones, even an ankle. So you may have to say, are you changing your neural feedback to the muscles? Is that being affected? We don't think about it. And normally you don't have to think about it. The brain can control it. But as you age, actually, you will get uh, deficits in some of your controls. I've been talking to some of the older people here. We all say we have to hold on to handrails now. As the day goes on, we get tired, so we might be changing things we do. So one, you might have trauma, but if you just observe people walking, and you'll notice that everyone walks different styles, different maybe nationalities, maybe different weights and males and females, and that's all controlled by neurofeedback too. So it becomes a situation of saying you can't just probably look at one cell, one tissue, one possible, remedy to the problem.
right. Even putting them together seems to be quite challenging. What you see here is like
Yes.
people who are working in cellular level, if they want to just come up with something or like talk to people who are in tissue level or organ level, it's still very challenging. And then
It's
finding something to help the patient
right.
would be another level of
I
challenge.
mean, at this meeting, I'm really surprised at the interaction of all levels, multi-scale levels, going from the whole patient down to the cell. I mean, there's a lot of collaboration. I think it may be because of New Zealand and Australia being close to each other, or needing to do the collaboration. It seems to be a lot more collaborative than in the States, though we do have collaborators in our own country and outside. But here it's especially at the University of Auckland. Actually, I see all levels of people interacting, which is what needs to be done. It's not easy. It's not
That's
easy. You have
definitely
to.
definitely. So what do you think with the, so you have been pretty much like in the last 50 years, you have been seeing the changes
Oh,
in the whole, let's talk about like osteoarthritis for the moment. What do you think would be should be done for the next, I don't know how many years, to sort of, can we find any cure, or is there any, or we should not really talk about cure?
no, I mean, a lot of us old timers will say uh, everyone's looking at the same things we looked at, but they're looking at with better instrumentation, finer detail. Uh, but some of it is becomes so detailed that sometimes they lose track of some of the basic things. And a lot of it has to do with you still need to talk to the clinician and the patient. Uh, but I think things are advancing. At this meeting, there was a lot of in vivo studies with patients. I said, looking at muscle, looking at gait, looking at their interaction. Also imaging. There's quite a bit of imaging going on. And so what you're going to need to do is get some kind of diagnostic uh, techniques to be able to maybe diagnose. We're talking osteoarthritis. I mean, when patients come in with pain, that's easy. But most of them, won't have pain, and they may have horrible looking joints. So one of the major problems is, one, can we diagnose it in very early stage? Can we even diagnose it, or predict who might get arthritis? That's really difficult. Even diagnosing at early stage. When you come in with pain or you have trauma, you know that you should follow that patient. But even that, there's no good methods to look at uh, the progression of the disease. Is it really getting worse? Regular X-rays, MRI, and then also, if we do get a treatment, how are we going to monitor the treatment if we really can't get the resolution we need to look at the disease? Yes, patients say, I feel better, I don't have any more pain. That's a good indication. But it doesn't mean that you still, the joint isn't breaking down. So it's a challenge, which I think is going to take a while. I mean, there's a lot of work going on in tissue engineering, but that, over my 40 years plus, still is not really been used much. It's still in it. It's still lots of information coming out, but can you replace something in the body that'll actually work? And we really haven't seen anything in general doing that.
So is there, I was talking to a professor here actually, another professor, and he was also like a 20 years or so in this area. And I asked him, what is the problem? How can we resolve, all these big issues that some of them you mentioned, the major questions basically. And he was telling me that we need more money. Is that right? Or
So money helps. Money helps. It helps hiring the right people, getting the supplies, getting things done. But I think one of the things that we're kind of lacking, and it's a problem with the academic environment, that everyone needs to get grants, write papers, get things out. It's very stressful. It's very hard. And even in industry, you have the same kinds of pressures. What we don't do, and even in my own group, it's very hard. I try to get them. I was telling somebody today, if we could sit down for 2 hours once a month and just talk ideas out, talk what kind of new things can we do that are out of the box, totally different kinds of things. What do we think? What's going on? Uh, you might come up with new ideas and really pursue new ideas. The problem with funding agencies, and they try to, get over this is you get money to do a project and you kind of stick to that project. And it's very hard to propose, new, risky, high impact kind of research. However, NIH has special grants for that type of research. It used to be called, and it's still high impact, high risk. It's not huge sums of money though, but it's enough to say, I want to try something to see if it works. One of the difficulties even with researchers is you try a few things, it doesn't work, okay, then you go and try something else. And a good researcher will say, if it doesn't work, I need to figure out why it doesn't work. There are two choices. I did something wrong, there's some other mechanism I missed, or it doesn't work. And it's very hard to do that because you have to have the willpower to say, it's a good idea, why didn't it work? And not just saying, it didn't work, let's try something else. I've been doing that
Right.
in my career, but again, you have to generate money also.
Exactly. So this is actually amazing. I would love to listen to when you're talking about all the overviews and then how the funding works and stuff. But at the end of the day, the whole thing that we do, we want to help patients, or we want to really diagnose earlier. We want to do something for the public, right? Let's say
Yes.
biomechanics, we are here. So of course we are dealing with. We try to understand and analyze things, from the scientific point of view that not necessarily have implication right away for the
Mhm.
patients,
Yep.
but eventually they would. So there's one is that idea, but then as you said, like there are issues with regards to, let's say, the funding and stuff that people cannot really do this. And there's another way of what you mentioned was amazing, that we don't sit around and exchange ideas that would be like totally out of box and they'll make a big difference, in one area or another.
Right.
So you were telling me something that was really amazing, that you were with pharma people and they weren't interested, because it wouldn't generate, or I don't know what they were thinking.
It would take too long and too complicated. Yes.
That is something maybe challenging, because musculoskeletal is a big issue. It's a very big issue. Like last year, I was in a meeting that they were talking about like Australia and then the priorities. Musculoskeletal is huge in terms of pain,
Yes.
in terms of cost and everything. But it was the priorities was all the other diseases, and then there was other, and below that it was musculoskeletal.
Wow.
So it is really sad.
It-
Maybe
it's a challenge because in the United States and every country, musculoskeletal diseases, problems, arthritis, injuries, it costs the country more money in labor loss than anything else,
anything else.
except it's not a dangerous thing. Cancer,
Sure.
heart attacks.
Definitely.
People worry about that because it kills. Musculoskeletal injuries will injure, but usually don't kill. So, but it costs certainly in the United States, unemployment costs, unemployment
Of course,
payments, loss of work. I started one of my talks off by saying I was reading in a local paper in New Zealand that the Minister of Health said that 13% of musculoskeletal injuries, of injuries in general, are musculoskeletal, and they cost New Zealand a large labor loss.
Wow.
And that's a large 13% of injuries being musculoskeletal is high.
Which is huge, exactly. So we know that that's really important. So if we get back to let's say osteoarthritis, imagine we resolve all these issues of funding and everything. We give you everything, and with all your experiences, what would you do at the moment for the next 10 years?
It's a good question. I've been interested at the very small level to see damage. Now, so in one of the key things in all tissues is collagen, and collagen can be degraded and can be broken. It can be broken mechanically as a fiber, but as a molecule and as the structural element that resists tension, especially in cartilage. When it gets cleaved, the cells cannot repair it. The cells could produce more collagen, but they can't repair the broken collagen. And in certain tissues, it's a very unique structure. The network is put together, and the cells will not weave that network. So things I have been focusing on is maybe ways to try to repair that collagen through either chemical methods or infusing in other things that might cross-link it. Uh, Even in tissue engineering, they want the tissues to grow and produce collagen, which they do, but whether they could put that collagen in the right orientation and structure, I have not seen that, at least not in this. Things like livers and maybe bladders and other tissues, you may be able to do that. Uh, and the reason is that a lot of tissues develop in maturation as you're developing from a baby. And the structure is set down. And at some point when you mature, everything turns off and it's structured. Uh, After that, there's very little turnover. And if you damage that tissue, it may be hard for it to, even if the cells produce the right components, it may not be able to put it in the same orientation and network because that was developmental. So that is maturation when you're growing up, and then there's adaptation. And everyone in tissue engineering tries to get things to adapt, to go back to the form that it was initially. And that has been a big problem. For cartilage, it has been a big problem. I have never, and all the cartilage researchers will say, they've never seen a cartilage replacement that actually looks like the original cartilage. Now, I always use the thing, if you do something and it grows in and it functions properly, okay? So if it looks like a duck and it quacks like a duck, but if it works like cartilage, that's okay.
That's okay.
The problem is that doesn't occur.
The function,
now,
basically.
The function, you need to get the tendons and ligaments can grow and produce collagen and can repair itself. Bone repairs itself, and many other tissues do. Cartilage happens to be unique, but there's probably other things. You talk about nerve cells and muscle cells being damaged, spinal cord breaks. Can you try to have that self-repair itself? And they're getting methods to do
closer.
that, but that's a big thing. Getting the tissues to produce and get the structure. But function, if it functions okay, and if it will last for a long period of time, our clinicians, when I talk to them, they just say, if you could give me 5 to 7 years more in a repair, I'd be happy, because then maybe we could do something else. Rather than things like getting a total joint or doing something else. Give us some time. And that's a philosophy. I've gotten a little involved in cancer.
Right, that's amazing area.
And the cancer, and some of it's been here, say, hey, if you could get a month or two more, or 3 months with a drug, they tell me that's a major accomplishment.
Right.
Now, in orthopedics, that isn't.
Yeah.
You're talking at years, but so maybe some of the things to do is say, well, we could do certain repairs, we could do new kind of conceptual ideas.
Maybe this is amazing. I'm actually enjoying when you're putting all this together, like in terms of tissue engineering and from the maybe a biochemical, you can intervene, or even mechanical point of view. But this timeline that you're talking about, maybe this is a shift that we may not just think about, we'll find out something that will function like a cartilage and that's it. Maybe we would need to extend it slightly so that other methodologies can be used to sort of.
I think they need to. It's still a long-term project. I mean, the companies will say, they've said to me, well, 5 to 10 years you could develop something, and they go, that's a long time. Now drugs, I think the number is $1 billion.
That's right.
$1 billion for a drug to actually start and come to market. They say
10 years or so.
And that's still a long period of time.
Exactly.
But the amount of money is huge at the end. But I've been seeing the numbers. 1 out of 24 even make it to trials.
Yeah.
So even in our situation, we could look at something, but we'll probably have to follow it in the musculoskeletal system for a good number of years. Pain reduction, though, is one of the easy things you do. You could take, NSAIDs, you could take even aspirins, and get the inflammation down.
Right.
And the patient will feel better, but that doesn't solve the problem. The problem still exists. The pain goes down, the problem is still there, and it's still going to take a long time. Especially in arthritis, osteoarthritis, we still really don't know what causes it. Where this conference, it's kind of clear that certainly it's a mechanical initiation of damage, but is it a change in how you walk? Is it just
Biochemical changes
by
or
it? Well, they'll drive the mechanical things will do something to make the cells act differently,
Yep.
and it'll become a biochemical, a molecular change.
Sure.
But again, we're still not really sure what goes on. When you have an injury, okay, you've injured something.
That's right.
We know it's going to start degrading, so we could at least know when it occurs. But in regular arthritis, who knows when it starts? And that is going to be a
That's tough.
real big challenge. Yes, there may be genetic factors. I was talking to some of the people. They're saying, yeah, there's some genetic, but it's alone is not a genetic problem. It has to be
Right.
coupled with other things. And it's tough. A friend of mine said he was developing a sneaker that would change the way you walk,
That's
that
right.
would take the loads off. We laughed when I talked about it. It says, how are you going to get everybody in the world to
To
wear this one ugly looking
Yeah,
sneaker,
exactly.
maybe, where they're not going to use it? And when I asked the clinicians, even just about a month ago, I asked one of the clinicians, how do the patients tolerate the braces to help you with, correcting walking? And they say they'll wear them for a few weeks and then they throw them
And
away because they just don't
exactly,
want to wear
'cause they don't
them.
want
And so compliance, which was a shock to me, I didn't realize
Sure,
that.
sure.
You'd say, hey, I've got something that'll help you and you'll be much healthier.
That's right.
But you say,
But-
well, it's ugly, I don't want to use it. It's too much work.
Exactly. Maybe this is another area that you actually touched, basically in terms of that we need to talk to clinicians, we need to talk to patients.
Yes.
Like this in this kind of conferences, we don't have many of them right around. So they're not, or there are of course like ORS or these type
Right.
of things, clinicians involved, and there are really those kind of conferences. But when engineers get together, so
Well, I'll tell you something. This is a great meeting. So I think a lot of us senior people have started to realize big meetings with 2,000, 3,000, 15,000 are just places to go and present something with very little feedback. And we've
Understand,
started
yes.
to enjoy meetings with
Smaller.
100 to 500 people.
That's right.
And doesn't have to be so. For bioengineering, we hold a summer
Yeah, that's
bioengineering
right.
meeting uh, where it's a smaller group, and it doesn't have to be focused. I mean, there's all different areas, but you could really get together and have workshops and talk with people.
Sure.
And the meeting here was like that.
like
There
that,
was
okay.
a lot of interaction going on.
Yeah, I
with
agree.
questions.
I totally agree.
And then going out and having coffee break together and
Exactly.
interacting.
Interacting.
They're very big meetings. Most of us are saying, you go to present your work. Young people get to meet other people,
Exactly,
and
yeah.
they get to. But it's very little, really innovative thinking. Too many things going on. Too
This is-
busy.
exactly.
I mean, when you have 6 sessions running
Running the same
simultaneously,
time. Yeah.
So
That is a major issue.
Yeah.
But thank you very much, Peter. We were supposed to talk about 5 minutes, and now it's 20 minutes.
That's okay.
No, that's fine. I really enjoy talking to you. And if is there anything that you would like to share with all
No, I
of us?
just have to say it's been a pleasure always coming to New Zealand. It's
That's
become
awesome.
my favorite country to visit.
Great. You should come to Australia as well.
I'm going there
Are
on
you going?
Saturday.
Yes, definitely. Thank you very much.
All right, thank
Have a
you.
wonderful visit.
Yeah,
Bye.
great. Good interviews. Yeah.
Yes.